Welcome back to Oncology for the Inquisitive Mind. That's Josh, and even though he can't see me due to internet issues, rest assured I am still Michael. We are very excited today because we're late to the party, as we usually are. But we are here at the glittering, the prestigious Oncology for the Inquisitive Mind ESMO Awards. Move out of the way, Oscars. Emmys, you're completely redundant. This is where it's at. This is where all of the best and brightest seek to make their mark. My co-host, as always, the Billy Crystal to my Robin Williams, is the one and only Josh Hurwitz. Josh, how are you today?
I'm good. Thank you for... I would have been happy with Billy Crystal or Robbie Williams in this particular instance, but I'll go with Billy. Look, I'm doing well. Finished the day, sun's setting. I would say it's lovely to see your face. It's not because I can't see it. Those beautiful brown eyes are no longer there. But why don't we get started for ESMO 1 of 3? We're doing 3 episodes this time?
That's the plan. Now, before we launch into it, a bit of a disclaimer is that we were hoping to do our usual episodes with guests from hither and yon and get their expert opinions. But life, unfortunately, or fortunately, has intervened because, drumroll, Josh has had a baby. Yay!
Yes, well, thank you. Not me personally, although biologically, let me know if anyone's ever done that. But my wife did have a baby, and I actually took some time off this time. So the first time Mark and I did one of these recordings, I had the first baby in arms, asleep as I was editing said episode. And such is life. I decided to actually take some time off, which is rude, but so be it.
Yes, self-care is very important. So what we are planning on doing, as I mentioned at the top, is an award ceremony where we talk about some of the really cool stuff, or at least the stuff that we think is cool, coming from ESMO 2025. It's worth noting these are our favourite trials. This is our personal opinion. We apologise if your study or your favourite study didn't get a gong. This is purely our opinion. But Josh, why don't we get started?
Yeah, so these are the nominees, Michael, and it's the evening. So as all our listeners know, I get very tired in the evening. So we're going to try and make this quick.
The nominees for which category?
The favorite trial of translational science.
A prestigious category.
Okay, so the first trial,
it's not going to be relegated to the outbreak.
No. Stay tuned. So this trial was called the SARS-CoV-2 mRNA vaccine sensitized tumors to immune checkpoint blockade. I've already lost, but essentially looking at mRNA vaccines, seeing if you inject it into the tumor, do you get a response? So the background is that they thought that it could sensitize it to immune checkpoint inhibitors by a surge of inflammatory cytokines. They looked at non-small cell lung cancers and melanomas treated for about 3 years, had PD-L1, and then they administered the vaccine within 100 days of it initiating the immunotherapy agent. And what they found was that it did sensitize tumors to ICIs or immunotherapy agents in preclinical models and are associated with substantial improvements to overall survival among patients with non-small cell lung cancer and melanoma treated with immune checkpoint inhibitors. So that's kind of cool.
A very interesting trial, Josh. And, we are hearing a lot about vaccines in anti-cancer therapy these days. So it's nice to see that a vaccine that got a lot of airtime might have some impact. The next study, because we're going through the nominees very quickly here. The next study is the safety and performance of a multi-cancer early detection test in an intended use population, the Pathfinder 2 study, finding the path for cancer detection and prevention. So this is a prospective multi-center interventional study that enrolled patients aged more than 50 years old with no clinical suspicion of cancer and no cancer diagnosis or treatment in the past 3 years. And the idea was looking at the safety and the performance of this test. And the test, the MCED, detected a cancer signal, and then underwent diagnostic evaluation if that signal was positive. They're planning a 3-year follow-up, but this is the results for the 12-month follow-up. And the first CSO or cancer signal origin accuracy was 91.7%. And the episode sensitivity during the 12-month follow-up was 73.7%. And remember, these are people that are effectively picked off the street. Of 133 MCED detected cancers, 75.2 do not have common screening options. And we talk about this with things like ovarian cancer. Very important to have good screening options. And of 114 new primaries detected with this test, more than half were stage 1 and 2, and more than 2/3 were stage 1 to 3, still curative. It's a great test. It's a great study. Obviously, I'm sure there will be lots of kinks to iron out, but well worth a nomination for favourite study in translational science. But Josh, the winner in this category, take it away.
The winner. I thought you were doing the winner for this one. Did either of us? Is this
You can
go on?
I can do it.
I can do it.
I'll do it. It's fine. I've got the golden envelope.
Yeah. Michael, why don't you do it, and I will listen to your dulcet tones.
All right. Well, this is the Monstar Screen 2 experience. This is a Japanese study, a comprehensive multi-omics analysis of early onset cancer. And the interesting thing here is what they did was, we know that early onset cancer is a growing problem. And EOC is defined as a diagnosis of cancer under the age of 50. It's increasing, particularly across the Western world. The authors analysed cases from a previous observational study that was run from 2021 to 2024. Tumour tissues underwent whole exome and whole transcriptome sequencing, or WES, at a centre in Phoenix, Arizona, in the US. And cancer types with greater than 100 cases were included in the analysis. The main aim was basically trying to answer that age-old question, which is, are cancers in young people different in any particular way or any noticeable, exploitable way to cancers in older populations? Now, there were almost 2,500 people in this study, which is the largest population of young cancer patients that I've seen in a study such as this. The most common cancer types were colorectal, gastric, prostate, breast, pancreas, head and neck, urothelial, renal, and biliary tract. A lot of those do have familial syndromes associated with them, and so perhaps that's not particularly surprising. But what is surprising is that breast is actually not one of the top two. I believe it was colorectal and gastric that were actually one of the top two most frequent cancer types in this study. In the whole exome sequencing analysis, there were significant genomic differences between early and late onset cancer. For example, in colorectal cancer, APC mutations were less frequent. Now, APC plays a role in controlling cell division, adhesion, and migration, and is responsible in many cases for the development of familial adenomatous polyposis, or FAP. But it is very commonly mutated in cases of colorectal cancer, but interestingly less common in young cases of colorectal cancer, whereas AXIN 2 mutations, which are involved in the regulation of B-catenin, which is again involved in regulating cell-to-cell adhesion and gene transcription, were more frequent. So, and this is what the pattern of results. We won't go into the nitty gritty or the nutty grutty, as we say on the show, but it was there were these sorts of very interesting patterns. Now, it is important to say that it was a very heterogeneous cohort. There were a lot of hypotheses to test, and none of the mutations really stood out. This came up in the discussion. None of the mutations were like, bam, this is something that is very indicative of early onset cancer. However, the mutations of CDH1 in gastric cancer and ATM in pancreatic cancer, were statistically significant in their frequency, more frequent in early onset cancer. And the other limitation to this study was that there was no information about whether these were germline or somatic mutations. Obviously, as I said, we're talking about young people, and there are documented higher rates of cancer predisposition syndromes in this population. But still, a really interesting case, and the reason we've picked it for our winner, and don't worry, the award will be in the mail. The reason we picked it for our winner in this category is just because it is focusing on an emerging problem, which is the early onset of cancer.
Yeah, really, really interesting stuff, Michael. And it might actually indicate where we take research next.
Exactly. I think this could be one of those studies that we look back on, whose significance will only be known in the future.
That's it. And moving on to our next category, Michael, which is the favorite trial for non-medical oncology. So this is like supportive care type trials. I might take the first because you so eloquently did the last
Please
winner.
do.
It's a randomized trial of continuing or de-escalating bone-modifying agents after more than 2 years of treatment in patients with bone mets for breast or castrate-resistant prostate cancer, titled the React Hold BMA. So, if you don't know, or maybe you do know, bone modifying agents given every 4 weeks or every 12 weeks to reduce skeletal events. And after a couple of years, or even after a couple of sessions, most patients start to get a little bit annoyed when it comes to that. So this is a multi-open labeled trial that after 2 years, they either continue to standard therapy or then reduce it to every 24 weeks. The primary endpoints were physical function, and the results essentially were about 240 patients, but I'll go to the conclusion because we're doing this quick. In this patients, those who were receiving long-term bone-modifying agents, de-escalation, preserved physical function without increasing functional interference and maintained SSE outcomes, which is skeletal events. And so essentially it's showing you could potentially de-escalate. Is that right, Michael?
That is 100% correct, Josh.
I am 100% correct.
A wonderful summary.
Amazing.
and quite timely because I actually saw a patient who had to stop bone modifying agents because they had that horrific osteonecrosis of the jaw just last week. So
Oh God.
it is timely. Yeah. It's really not a pleasant thing. So we love a de-escalation study on this show. I might move on to the next nominee, which is a study on, and I'm going to try and get this right, ponsegromab, which is a monoclonal antibody that is indicated in the treatment of cancer-associated cachexia. And Josh, I think we spoke with Professor Janet Abraham for the ASCO series about a similar study looking at cachexia, and it's very, very exciting, very important. Ponsegromab is a first-in-class monoclonal antibody that inhibits growth differentiation factor 15, or GDF15. And the idea is that this was a double-blind phase 2 trial in which patients with cancer cachexia and elevated serum GDF15 receive subcutaneous ponsegromab at a rate of 100, 200, or 400 milligrams, or matching placebo every 4 weeks. And at 12 weeks, participants could pursue open-label treatment with ponsegromab, 400 milligrams every 4 weeks subcutaneous. So this is not a heavy treatment. It's not a very involved treatment. It's a subcutaneous injection every 2 fortnights. Changes in body weight and safety were assessed through weeks 64 and 72, respectively. So what we are seeing with this is there is a mean difference in body weight change compared with the ponsegromab at different doses and placebo. So in terms of patients who were on, and I'll just take this because we're trying to be quick, on the 400 milligrams throughout the study, at week 12, there was on average, a mean increase in weight of 2.8 kilos. At week 24, 4.1 kilos. At week 52, 5.15 kilos. And at weight 64, a massive 7.61 kilos of weight gain, which for patients with cancer cachexia is such an important aspect, because it's not body fat that these people are losing, it's muscle, which leads to decreased bone strength, which leads to decreased energy. It's really important and really debilitating for those that suffer it. So a fantastic addition in the supportive care sphere.
Absolutely, Michael. And as we know, people that lose weight don't do as well with treatment. The next one is probably a bit closer to home. Imposter syndromes and
Very,
maladaptive
very close to
professionalism.
home.
Maladaptive perfectionism, not even professionalism, among oncology professionals. It was a global cross-sectional study. Look, as we know, stress is pretty significant, and so is burnout, and this is nice that they're actually addressing it. And so essentially they were looking at this. So large-scale studies on the prevalence and predictors remain limited. The results are that 34% had high sort of imposter phenomenon scale. It's called SIPS. And Maslach, maybe, burnout inventory, or MBI as they sort of said it, was also very high. So the conclusion really for this is that psychological distress is common among oncology professionals globally and is influenced by both structural and psychological factors. Imposter syndrome and maladaptive perfectionism were associated with burnout, especially in younger professionals. These findings highlight that they actually need to target the way this career is heading and maybe actually look at workforce planning and supporting colleagues rather than just pushing it. Risk factors are those that are younger, Michael, female, and not having children. That's really it. So interesting study.
Yeah, I think it's saying the quiet part out loud, isn't it? The next study is a study that I thought was also quite timely because I actually came against this last week in my practice. It is the impact of proton pump inhibitor use and potency on immunotherapy outcomes and gut microbiome in patients with advanced non-small cell lung cancer and renal cell cancer. PPIs, I feel, are one of those medications that we give out effectively to kids on the street. We may as well, because they're very, very commonly prescribed. So in this study, patients with advanced non-small cell lung cancer, 531, and renal cell cancer, 183, treated with immune checkpoint inhibitors in France and Canada, provided baseline stool samples, lovely, for metagenomic sequencing. And PPI use at baseline was assessed, and potency was standardized using omeprazole equivalents, which I was only vaguely aware of. And they looked at overall survival as the primary endpoint. So, very interesting study. So, in non-small cell lung cancer, 27 patients received PPIs prior to commencement of immunotherapy. And amazingly, it was associated with a shorter overall survival, 12 compared to almost 19 months, a hazard ratio of 1.53. And we don't often have hazard ratios above 1 on this show, Josh. Particularly, and this was particularly relevant in those who received immunotherapy alone, where the median overall survival was 10.8 compared to 18.1 months and has a ratio of 1.6. And this was independent of PPI potency. So it doesn't matter if you're on 20 milligrams of omeprazole or 40 milligrams BD of pantoprazole, the effect is still there. And there is data on the microbiome that might explain this. There's potentially a shift in microbiome composition. Now, I will put my hand up and say the significance of a lot of these words that they're using here, I do not understand. But reading between the lines, I would imagine that we know that the microbiome is associated with whole body immunity. And so if there's some sort of shift, then that might give the immunotherapy less to work with. But a very interesting study and something to keep in mind. We talk about antibiotic outcomes with immunotherapy. I think that's very well known, but this is probably something that we also need to be aware of.
Very much so. Very much so. Well spoken, Michael. Why don't I move on? What would I talk about? The My Risk trial. Personalizing antiemetic prophylaxis for patients at high emetic risk results from the My Risk trial. So what we know is that nausea is bad, and we pretty much standardize antiemetics, which is, it's better than what it was 20 years ago. But the question is, can we do better? So in patients with elevated emetic risk due to personal risk factors, prophylaxis with highly emetogenic chemotherapy may be warranted. To address this unmet need, let's look at a personalized antiemetic strategy. So the MyRisk trial incorporated a previously validated predictive risk factor algorithm to select patients at increased risk of chemotherapy-induced nausea who may benefit from additional NK1RA medications. Which isn't that just palinositron and nitepatant?
Yes, it is. But
No, it is. There we go.
Patients with these sorts of chemotherapies don't always get the combination.
And Michael is correct in saying that. So it was a phase 4 randomized open-label trial. Adult patients received 3 cycles of standard, of moderately emetogenic chemotherapy with high risk score, and they were randomized to either the fixed combination of the high antiemetic regimen plus dexamethasone, or the standard of care. The primary endpoint was complete response with no emesis and no rescue medication during the overall phase over 3 consecutive cycles. The analysis used a generalized linear model, which is all very, very exciting. But why don't we look at the complete response? And so the complete response with no emesis was 81% versus 71% with a p-value of 0.012. Complete protection was 71 versus 62%, again statistically significant with a p-value of 0.022. No emesis at all, 95 versus 86%. No nausea, 63 versus 54%. And no rescue medication of 82 versus 76%. So it sort of speaks for itself, is that the novel trial integrating pre-medication individual risk factors with planned sort of moderate emetogenic chemotherapy found that having this sort of increased regimen was superior to the standard of care in preventing chemotherapy-induced nausea and vomiting, which then hopefully impacts the fact that they will continue with treatment and not want to stop. Some note is there was no consensus regarding the addition of the NK1 agonist to the metoclopramide antagonist and dexamethasone. Some guidelines suggest in certain situations this addition could be beneficial. And those that have the more moderate emetogenic chemotherapy, there was sort of an algorithm and you had to have sort of more than sort of 13 in this particular case. And they spoke about risk factors for that as well. There was no significant difference in the acute phase, but it was statistically significant in that 120-hour period. But overall, it seems that we should be moving to probably an increased regimen, although in Australia, this tablet costs about $50. So it's not a cheap tablet for people to use off the pharmaceutical benefit scheme.
No, absolutely. And I think the reason we chose this as our winner is we do love some personalized medicine. And if you're getting a regimen that is not considered to be emetogenic enough to meet the criteria for palinositron and nitupatant, but you have some of these risk factors, and they included being younger than 60 years, reporting an expectation or anticipation of nausea and vomiting, and having a history of morning sickness during a previous pregnancy, that sort of thing. Or if you're about to receive a platinum or anthracycline chemotherapy. And again, I think this is where our PBS is actually along similar lines, because an anthracycline or platinum basically automatically gets you access to the combination, but you are more likely to have more severe vomiting than someone who doesn't have these risk factors. So lovely bit of personalized medicine. And that's why it was our winner for the favorite trial in non-medical oncology, Josh.
I like it. I like it a lot. Shall we keep going?
Let's keep going, and I believe that we might have grossly overestimated how much we can get through in one of these episodes. So even though we said
I was thinking the same thing. What?
even though we said this is going to be a series of 3, as is always the case, I suspect it's going to drag out significantly. But, Josh, why don't we call this our last one for this episode? This is the favorite trial in an area of unmet need or in relation to rare cancers. And the first nominee is, again, I feel like I'm just picking stuff that answers questions that I've had in my recent clinical practice, because this is the perioperative pembrolizumab for locally advanced thymic epithelial tumors. Now, thymic epithelial tumors, or TETs, are frequently considered potentially resectable, but all it takes is one glance at a netter's anatomy book to know that where the thymus is an incredibly difficult and anatomically busy part of the body for our surgical colleagues. And so anything that we can do to make their job easier and reduce the risk of damage to major blood vessels, or needing to do lobectomies because the lung surface is involved, is going to be of benefit. So rather much like the title suggests, this was a single-arm prospective phase 2 trial in which patients with potentially resectable TETs with the Masoka Koga stage 3 or 4, and I'll be honest, you're going to have to look that up yourself, received neoadjuvant paclitaxel, cisplatin, and pembrolizumab every 3 weeks for 3 cycles. This was followed by surgery and maintenance pembro for 2 years. And the tumor response was assessed using CT and PET-CT followed by surgery. And R1 and R2 resected patients received adjuvant radiotherapy as well. So 40 patients were included. 7 had WHO B3 thymoma or thymic cancer. 29 had TC, and 31 had stage 4. The median follow-up duration was 23 months, and the baseline tumor proportion score was greater than 50%. But there was promising rates of major pathological response and R0 resections, as well as promising long-term DFS in these populations. So for a space that doesn't have very much in the way of treatment options, and as I said, I had a case very much like this where there was a young lady who had a very large thymoma, and there was a question about neoadjuvant chemotherapy, and we said, look, there's not very much evidence that it's going to help. And she ended up actually having just a fairly morbid thymus resection, but this would have been perfect for her. So that's why I put it down.
That's great. It's a light moment in our discussion point. But let's move on to the LightSpark 15 trial, which is belzutifan in advanced. Thank you. In advanced pheochromocytoma and paraganglioma. I must confess I haven't treated either of these. And so this was all very interesting reading through it. They're neuroendocrine tumors, for people who wanted to know, of the adrenal medulla or extraadrenal paraganglioma, with limited options, therapy options not approved. So there's a HIF2 alpha signaling, which is a major driver of this cancer type. And the LightSpark 15 trial evaluated the inhibitor, belzutifan, in advanced paragangliomas. It was a phase 2 trial, and it was a small trial. There were 72 patients with a median age of 51, and the median number of prior therapies received was 1, because probably there's just not very much. The conclusion, though, and the objective response rate was 19. I think it was 19%. There was no one that had a complete response. Partial response was 19, and stable disease was 42, and disease control rate was about 84%. So if you're looking at sort of partial response, it's about 25%, and stable disease is about 58%. The median duration of response was somewhere between, it wasn't reached, so it was about 2.7 to 24 months, and the 12 months duration of response was about 65%. So the conclusion is belzutifan provided a clinically meaningful anti-tumor activity and durable responses in patients with advanced paragangliomas with manageable safety and side effect profiles. And so that's, I think, actually really exciting. And of course, the overall survival rate at the 2-year mark was 75.5%.
Very interesting. And the reason we put this up is because paragangliomas, as Josh said, many people go through their entire careers without treating one of these. But I think the standard chemotherapy option is CVD, cisplatin, vincristine, and maybe dacarbazine. And it's very, very toxic. And so anything that betters that, at least in toxicity, is worth a mention.
And so, as our final trial, we're going to do the Impress Norway trial. I'm assuming they were very impressed. It was the clinical benefit of genomic-guided targeted therapies in patients with rare cancers. And this is the winner, which is the first result of the Impress Norway trial. So rare cancers, about a quarter of all cancers in Europe, maybe not that rare. And due to the low incidence of individual tumor types, data on new therapies is unknown. This trial provides access to select targeted therapies outside of their approved indications. Here they presented the first results in treatment outcomes in rare cancers. So the key inclusion criteria had to be a rare malignancy, life expectancy of more than 3 months, an ECOG of 0 to 2, evaluable disease, and the primary endpoint being that a percentage of patients offered treatment, disease control rate, safety, and the secondary was PFS and OS. There was a screening phase, and there were samples were collected, genomic analysis was done, and then a national molecular tumor board occurred. Then they were included in treatment cohorts, or then referred to standard of care. The treatment cohorts was defined by tumor type, molecular target, and study design. The results is that during over about 3-year period, 1,100 patients with rare cancers screened for trial, median age was 58, slightly more females. And the conclusion that access to comprehensive genomic testing ensures the identification of actionable genomic alterations. The results suggest that patients with rare cancers may have a clinical benefit from targeted treatment, which is interesting. So 161 had a minimum follow-up of 16 weeks, and the disease control rate at that 16 weeks of treatment was 46%. Which is interesting. So the notes, majority of patients had less than 2 lines of therapy. The most common identified targetability mutation was BRAF V600E, and a high tumor mutational burden, PIK3CA, and ERBB2 amplification, and NRAS mutation. So that's quite interesting because it shows that if we just sequence everyone, then maybe we'll actually get an answer of something that could potentially work, even if the data is limited. I hope you've enjoyed the first episode of our ESMO Awards series, of which hopefully when Michael's internet picks up and I'm slightly less tired, the subsequent episodes will be a little bit more invigorating. We look forward to seeing you next time.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.